Hi, my name is Raj Mehta. I'm going to be going through a brief introductory video on insulin and diabetes management in the hospital or inpatient setting. The objectives of this video is to briefly go over the background of insulin therapies, discuss determining glucose goals, and how to determine different insulin dosages for your specific patients. We'll briefly go over how to convert between different types of insulins, and then we'll discuss the management of DK and HHS and insulin requirements. Okay, the first thing we should probably start with is what exactly is insulin, or 1 unit of insulin. So we discuss insulin in terms of units, and it's important to know what we're talking about. The original definition of 1 unit of insulin was based on the amount of insulin required to drop the blood glucose in a fasting rabbit to 45 milligrams a deciliter. So that was the old definition. It was standardized. There is now an international unit determined by the pharmacological and biological activity of insulin, and it's equivalent to 34.7 micrograms of pure crystalline insulin. And that roughly is enough insulin to drop an average person's blood glucose by about 50 milligrams a deciliter, or it can cover about 15 grams of carbohydrates. So it's kind of an idea of how much 1 unit of insulin is, and that is regardless of what form that insulin is in. So it makes it standardized. Now, although it's called an international unit, we usually write it in terms of U and just discuss units, because if you write IU, sometimes that I can be confused with the number 1, and we don't want to have to deal with those kinds of problems. Next, let's discuss the different types of insulin available. We'll scroll down here to some graphs I have. The basic categories of insulin are your fast-acting on the left here. You can see here on the graph on the left, the fast-acting like insulin, Lispro, Aspirin, they usually work within 2 to 3 hours. And on the right, you can see them over here. These are your fast-acting insulins. Onset is usually less than 50 minutes, peak in 1 to 2 hours, and usually by 3 to 6 hours they're complete. Next on your category is your original or regular insulin. So regular insulin, as you can see here in the graph, lasts a little bit longer, 30 to 60 minutes onset, 2 to 4 hour peak, and then it kind of comes out at 6 to 10 minutes. And then after that we have your long-acting. And the long-acting are separated into 2 different forms. You have your NPH, and then pretty much your Lantus and your Levemir. Your NPH lasts about 10 to 18 hours, and usually you have to do it in 2 times dosing to have full coverage over the day. And the Lantus and Levemir, as you can see down here in this picture, sorry, the yellow doesn't work so well, lasts usually closer to 24 hours, and you can do this once daily. Now, a lot of times people market Lantus and they say, oh, it lasts straight during the duration of 24 hours. That's not completely accurate. It does tailor off, but it's pretty good. Another interesting thing to note is that between dosing NPH, BID, and Lantus and Levemir, I'm not aware of any studies that shows any mortality benefits between the two, and NPH is oftentimes a lot cheaper for a lot of patients without insurance. So don't think that just because you're giving your patients NPH that you're giving them anything substandard to their care. The last type of insulins to be aware of are the premixed insulins, and the advantage of premixed insulins, sorry for my hiding there, is that it contains rapid acting and short acting, and they're usually named after your short acting because the long acting is always going to be NPH, and then it's written 70-30, implying 70% is NPH and 30% is Novolin for Novolin 70-30, or 30% Humulin for Humulin 70-30. And the advantage of these is you take them twice a day, say before breakfast and before dinner, so that you have your basal covered, and the short acting works directly or before you have your meal. So as you have your meal, the short acting will work and it will cover the dose you need. And the nice thing about this is for patients is that it limits the amount of time they have to stick themselves, because if someone has a separate insulin preparation for short acting, then they obviously have to do a lot more work. Let's move on and discuss determining in your patient how much insulin you should be giving them. So the way we describe this is the total daily insulin dose, TDD, and that determines how much dose a person needs every day, and 50% of that should be a basal or long-acting, and then the other 50% should be covered during prandial or meals, and that makes up your total insulin dose. Now, for someone who's never been started on insulin, this can be tricky to figure out, And in general, the amount of total daily dose depends on how insulin sensitive they are, or insulin resistant. The more resistant you are, the more they need. In the average type 2 patient, you usually can calculate or estimate this at about 0.5 to 1 units per kilogram a day. So a 100 kilogram person may need anywhere from 50 to 100 units of total daily insulin, and then you subtract that by half to determine how much basal insulin you need, and then the other half you try and give over meal coverage with your prandial insulin. For type 1s, depending how brittle they are, you can do this from anywhere from 0.3 to 0.5 units per kilogram a day. Let's go into a little bit more specific, because sometimes it can be tricky to figure out. So let's say we have basal dose here and prandial dose here. So let's start with a type 1 patient. So for a 100 kilogram person, I might have a total dose of about 40 units a day, and of that 40 units I may give like 15 or 20 units as a basal dose, and the remaining I'll give over prandial. In a type 2, if I'm going to give a 100 kilogram person, I might have 50 to 100 units, and half of that might be 25 to 50 units I'm giving as a basal dose. And again, if I think they're insulin sensitive, I might go to the lower end. If I think they're more resistant, I might go higher. Now the prandial dose, if you were going to calculate this out, would be the remainder. So if I had a type 1 diabetic and I wanted to give the remaining 15 over prandial, I could do that 5 units with breakfast, 5 units with lunch, and then 5 units with dinner, and I would have my total as I needed, up to 30 to reach my total daily dose. Similarly, in a type 2 patient, if I was giving 25 units, I might give something like 7 units for breakfast, 8 units for lunch, and 8 units for dinner, and that would give me a total of about 24 units. So if I was giving 25 basal and 24 prandial, I would meet 50 units a day, which would be a good starting place on a new patient. I find that a lot of people are usually okay determining the basal dose, but they have a lot more difficulty determining what the prandial dose for a patient's insulin requirement would be. You can determine your total daily dose, divide that by 50%, and then break that up into your 3 meals to determine your prandial dose. But if that's a method that you're a little bit uncomfortable with, there is an alternative. And you could use instead a calculation that estimates your needs for each meal. And this would be for breakfast, lunch, and dinner. And this is units per kilogram. So if you had somebody who weighed, let's say, 50 kilograms, then you could say, oh, that person, if they're type 2 diabetic, would need about 5 units for breakfast based on this, and then 7.5 for lunch and dinner. And that would be a good starting place to break it up. And for type 1 person, obviously, because they're a little bit more sensitive, you could use a prandial dose from 0.05 to 0.1 units per kilogram as your starting point per meal. So it would be a little bit less than your type 2, and then titrate it up as you need it. Okay, let's move on and talk about how to convert between different types of insulins. This can be really challenging because you might admit someone in the hospital who's normally on, let's say, 30 units of NPH BID, and you want to convert them to Lantus. How much daily Lantus would you give them? Well, this is actually pretty easy because units of insulin are usually equivalent, so 1 unit is always going to be 1 unit. The only exception to this is NPH. NPH, when given a BID dose, because it has a piece, is sometimes a lot more potent. So whenever you convert NPH to anything else, you just determine your total daily dose. There we go. And you multiply it by 80% of what that value is, and then you take that, and that will be your new basal dose. So in this case, 60 units times 80% equals 48 units. It's pretty straightforward. If I was instead converting from, let's say, Levemir to Lantus, and I had 40 units, then it would just be 40 units. If I was converting from Novolog rapid acting to Humulin, and I was giving 5 units, it would just be 5 units. So pretty much every time you're doing conversion, it's always direct, except for NPH. And whenever you're converting from NPH to anything, just take 80% of that total. Now conversely, if you're converting back to NPH, you don't add anything, you just do it directly. So if I'm going to go, let's say, from Lantus 40 units to NPH, what I'll do is I'll just take that 40 units and I'll do it twice a day. So I'll do like 20 units of NPH BID. Or some people like to do 2/3, 1/3, where they'll give like, let's say 30 units in the morning and then 10 units at nighttime. But those are different ways you can do it. Okay, I'm actually running out of time here, but I want to just briefly discuss with you what your glucose goal should be for your patients. Okay, I've already written the chart out for you, but basically your preprandial goal in diabetes, you want your sugars to be 90 to 130. Your postprandial goal is going to be about less than 180. And if your sugars get to 130s to 150s or whatever after someone eats a meal, it's not a big deal. And your bedtime goal is about 110, 150, and you can compare that to what's normal here. This value is especially important in the hospital setting because your goal should always be to keep your sugars in general below 180. When your sugars get really, really high, they can start impairing with the immune system. This is especially true when you get to glucose levels greater than 300. It starts interfering with neutrophil function, increases your risk of developing infections. It can mess with endothelial function. It's hard to control your blood pressure when your sugars are really high. And it can also compromise wound healing, among other things. So the goal is to always keep it below 180 in general, and you should be fine. Now the preprandial dose is going to be really important because if you have someone who has uncontrolled sugars during the hospital course and you want to start increasing their basal dose, your preprandial goal you're going to aim for is 90 to 130. So if their preprandial is like 180, you can increase your basal dose to get it to this value. But if your preprandials are consistently in the 100 and your postprandials are way too high, then you need to increase the actual amount of insulin coverage you're giving with meals. And using these kind of rough goals, you can kind of increase and manage the amount of insulin you need to give. Now there are some scenarios when you're taking care of someone when the sugars can be really difficult to treat, and that's when someone's under lots of stress, which happens in the hospital, or when they're on steroids, and sometimes they'll have steroids-induced diabetes and they don't actually have normal diabetes. In these situations, you should try and increase your insulin to try and meet at least the 180 goal, but keep in mind that once that period of stress is gone, or once they're off the steroids, the sugars are probably going to drop and you're going to want to cut back the amount of insulin you're giving them. There are times with patients that my best attempts to use just basal and prandial coverage just isn't doing it, just because their sugars are fluctuating too much. And if there is a concern of hypoglycemia, you really want to avoid this because this is a big factor, then it's okay to try and put them on a sliding scale if you don't have a choice. But usually you want to avoid the sliding scale if you can and stick with just basal and prandial coverage of insulin. Okay, my time is up. I didn't actually get to cover DK or HHS, but if you guys are interested, maybe I'll make a second video. I hope this has been helpful to you guys, and thank you so much for your time.